Club, we do officially have a website, parkerneurologyclub.com. On that website, we have shirts. If you guys would like to buy shirts from us here, let us know. We can order them. We'll start ordering them for you. We'll make a list. Actually, I'll get how to sign. We do one of each one. Pass on. We'll have a t-shirt order form and just the roll. So if you guys want a t-shirt, let us know. A lot of that money that we get from the t-shirts goes to help children who need difficult neurological care. So we're trying to raise money for them.
And Jason, can they buy them online?
Yep. Okay. So we actually made it easier to find online. It's right next to the home tab. There's the online store tab, and then there's all the other tabs. So it should just go to parkerneurologyclub.com, and then right next to the home tab, there's the online store. You can go in there and you can order a shirt off there. So we actually don't have one of the most popular ones is the baseball tee. It's like, you know, a normal baseball tee with the Keep Calm and Study Neurology on the front. So also, we're selling the next, for this series right here, we're going into our second series for teaching, and this is basically like the essentials of chiropractic neurology or functional neurology. It has a lot of really, really cool stuff. Like, I do the best I can with 30 minutes I have to go through as much stuff as I can, but if you guys get one of these, it would help me out, and it would help you guys out a lot in learning this stuff, because I can't go over everything I need to go over once a week with like 6 PowerPoint slides, where that stuff can help you out a lot, and it'll actually break down stuff. There's fill in the blank stuff that we'll go through. I'll hit all the high points, but you can actually go back in and learn that stuff. What would take you 8 minutes to read, you know, like it would take me 3 hours to teach. So it's just really easy for you guys. It's worth it. We sell them for 30 bucks. If you don't have one, I know a lot of you guys bought them today. So if you guys want one, talk to us after. Talk to Tyler after. Talk to Danny after. Where's Danny? Danny somewhere in here. Oh, he probably had to go back to class. Okay. So Tyler, Morgan, Morgan, raise your hand. If you guys are interested, talk to either Morgan or Tyler. Okay. All right. So in the next couple series, we're gonna hit. This is today. We're going to go back over that. We're going to teach more complex, explain that a little bit better, and also talk about some different treatments. We're going to start doing treatment in every single club, okay? And then later on, so you guys know what's coming, we're going to talk about looking for different autonomic findings, how to treat autonomics, cerebellum, different eyes. You see me a lot when I look at people. I just like make them track my thumb. And people are like, what are they doing in this chiropractic school? Like, why did you care about their eyes? Like, you'll see. That's what's coming. Vestibular system, and then a physical exam at the end. Once you guys know what you guys are doing, it'll be more. You guys will have more time to go in, find a friend, find somebody in class to be like, okay, I want to see, I want to see you walk. I want to look at your eyes. I want to see your sway. I want to do all this different stuff. Nick.
So guys, it's really fun to learn about treatments, right? But we got to learn how to spot the stuff first. So practice. You go to the mall, you go to the grocery store, just observe. Observe. You see something crazy, write it down even. Take a picture, whatever you want to talk about it, because we can show you all the coolest stuff in the world, but if you don't know when to use it or how to use it, or when the patient, like, what does Bell's palsy really look like? What does cerebellum instability look more like than vestibular when people are? So we got to spot this stuff, and that's really what we need to do. Is see the signs first, and then we're going to do about it.
And we're going to talk about that a little bit later too. We're going to talk about the 7 longitudinal levels of a lesion. So a lot of chiropractors come in, one of the big ideas of chiropractic is we want that nervous system to communicate with the body as well as possible, as good as possible. And that doesn't just mean a misplaced joint, right? We want to look at the receptor, we want to look at the peripheral nerve, we want to look at the spinal cord, we want to look at different parts of the brain. Because all of those could have a subluxation component, right? Where something's not firing, those pools of neurons aren't firing as well as they could be. So it's not all about a bone to the left. We want to look about different muscles, muscle tone, we want to look about all these things, because all of them give us a different window into the nervous system, right? We want to talk about, kind of like what we did last time, about the muscles, the paraspinals of the spine. Paraspinal muscles, yeah, whatever. Redundant, my bad. Are they volitional? Do you move them on purpose, or are they reflexive? Reflexive. That's huge. We made the point that you can't just take C6 and move it to the left on its own just by thinking about it, right? So we want to break down all these different things and wonder and kind of understand why those bones are moving the way they're moving. Whether it is vestibular, whether it is an eye component, whether it is you guys were in the gym and you guys are working out the wrong way, in a non-functional way. You know, we want to talk about all that kind of stuff, and we will. All right. So for review, what are the 3 things every neuron or pool of neurons needs to survive? What's the first one? Oxygen. Fuel can be broken down into 2. So oxygen will kind of be fuel. Let's heard it. Glucose and activation or stimulation from the previous neuron. A neuron has to fire to another neuron so that neuron can be healthy, right? If nothing fires to that neuron, it's going to end up dying, okay? Or it's going to go more towards death. It's not going to be as well or as healthy, okay? So with increased fuel and activation, there's my little pointer. The neuron, I like this other one, man. This one's like a lightsaber compared to mine. Boom, okay. With increased fuel and activation, the neuron becomes more stable and may grow. So what's plasticity? Ability to change. Who works out in here? Got a lot of people. I like to use exercise analogies because I feel like most people are healthy and most people work out, right? So in the first 8 weeks of working out, do you see a lot of hypertrophy? No. Do you see a lot of strength changes? You see a lot of strength changes. I can make people push about 50 to 100 pounds more in 8 weeks if I train them without hypertrophy. How is that possible? Because those neurons are way, way better at communicating with that muscle, right? That neuron can fire better. You have less Golgi inhibition. You have a way to fire those muscles better, right? So I think about that when I think of plasticity, is that neuron's ability to fire to the next neuron better. Whether that be neurotransmitters are increased, whether there's more synaptogenesis or there's more arborization where you actually have the dendrites branch out and talk to that other axon more, or that same neuron has more energy and more oxygen and more fuel and it can actually fire to that neuron better. Okay, so that's what we're talking about in chiropractic a lot, is we want those neurons as healthy as possible with as much fuel and energy as possible so it can stimulate the next neuron as healthy as possible. Does that make sense? Okay, so same things happen, actually the opposite happens with decreased fuel and activation. When you have decreased fuel and activation, the neuron becomes less stable and less able to handle the demand placed on it. So we're going to talk about something called transneural degeneration. So as that neuron goes closer towards death, it's not firing as much, it's not getting enough oxygen, it's not getting enough glucose, whatever that may be, its last stand before it dies is to basically dump all of its proteins and all of its, we'll just leave it with that right now. It basically takes all of its resources and dumps it, and it fires really, really close to threshold. So all it's trying to do is get another neuron to fire to it to stay alive, right? Like Castaway, like he uses like all his food and all of his resources to make his final like raft to go out in the ocean and be saved. What happens if nobody finds him? He dies, right? So that's like a neuron's last stand. If a neuron or a neuron pool is in transneural degeneration, it's really, really easy to make it fire because it's dumping all of its proteins that it doesn't really have in an effort to stimulate it. If you stimulate it and it's not too strong of stimulation, that neuron or that neuron pool can stay alive. Nick?
So basically, you gotta like glutamate from the top, right? Cell becomes leaky, releases glutamate. And then also, too, if you got an oxygen delivery problem, then how can ATP and all that stuff rephosphorylate? So it'll actually start using the cell membrane.
Hold up, we actually use biochemistry at this?
Yeah.
Oh, my bad.
So the cell becomes even more leaky because it's having to use the phospholipid bilayer as fuel because it's not getting oxygen too. So it becomes even more leaky and releases glutamate, and that's how you get this transneural degeneration stuff. So it affects, like you said, a pool of neurons, and a pool of neurons is like a bunch of guys and girls that like to hang out and can travel from this place to the next. So you'll see a problem here, you'll see a problem there. And you tell the difference between it'll fire really easily and then it'll fatigue really easily.
I think a main part too is when I'm teaching this, don't think, because I know like ever since like we've started basic sciences, when they teach you about a neuron, they do it basically so simplistic that it's wrong. They think like neuron A talks to neuron B, talks to neuron C. Like think about in the brain, there's like 10,000 synapses going on at the same time, right? So it's a huge pool of neurons. So a huge input or a huge output of the cerebellum is the cortex, right? So if you see the cerebellum going through transneural degeneration or midline cerebellum going through transneural degeneration, you see a huge chunk of cortex not being fired to. And then guess what you see in the cortex? That firing in the cortex starts to go down, 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 down. When you see decreased firing in the cortex, everything the cortex fires to can go down, 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 down. So then your autonomics can change and all that kind of stuff. And we'll get there. But all I'm trying to say right now, for you guys not to know that much stuff, is I'm just saying, don't think of it as neuron A, neuron B, neuron C. Think of like parts of the brain, because they work together and they talk to other parts of the brain, okay? So we talked about going back over this the last 2 weeks too. So if I actually adjust somebody, let's say a bone is out to the right, I kind of need to go back through this to feel better about the people who weren't here. So if you guys were here, sorry. I don't necessarily care if a bone's to the right, if they can still move that joint the way that joint's supposed to be moved, and the brain's getting activation from the movement of that joint through mechanoreception. Okay? Did I just blow anybody's mind? I care about neural input to the brain, because the brain has sensory, then it has central integration, and then it has motor. And you're not going to have a good motor output unless you have a good sensory input. If your sensory input is wrong because you have certain joints that aren't moving when they should be moving, that's when we have a subluxation, and that's when we have a problem. Okay? So, going back to this, where was I? So, we have a bone that's out, we adjust them, so they get a huge bombardment of neurological activity to the brain during that adjustment, but it lasted for like a fraction of a second, right? I want you guys to think about the rest of the day, or the rest of the week, or the rest of their life. When that joint's moving, that's activation to the brain, right? So for the most of you that are here, I know there's a couple of you that like weren't here and they're kind of struggling because I'm not going back through some of the other parts of that, but bear with me, okay? So you want activation to the brain through movements of the joint. So that's huge too, because going back to exercises, how many chiropractors don't have, or have patients that don't go work out? Like, it's not good enough to have a joint that can move, that doesn't move. Does that make sense? Like, great, you're not fixated. How often do you move? You know what I mean? We're not treating symptoms here. We're treating the human holistically, right? So treat them as a whole human. Get them to get up and move, do something. If that joint, or if the nerves in that joint aren't giving the brain information about movement, I don't know, I feel like they could be healthier than that, okay? That's a big point. Let them move. The motion segment or the joint is moving differently post-adjustment. The nervous system has changed, so that makes sense, right? So if you have the three major sensory, central processing, efferent, or motor pathways, they're going to have a better motor pathway because their brain knows where the joints are that are now moving. If the joint's not moving, the brain doesn't know exactly where it is. It can't control it as well. You could see different mechanical loading. You could see pain in the joint. You could see different things because the brain can't process that information, so it can't control it. Okay? This is kind of dry, so I'm kind of getting through this stuff. If you guys have any questions too, like, this isn't class, right? Anybody can just speak up. Cool? Okay.
And remember, all these are videotaped, and they're up every week.
Oh, yeah.
So you can get it on the website if you need to review.
Cool. Yeah, thanks, Matt. So here's the other thing, is I see a lot of people on either muscle relaxers or on a bunch of medication, and this is my pet peeve in chiropractic school, because I hear a lot of people who think they sound really smart, but they don't know anything they're talking about. I'm like, we don't need to know medicine. We're not, we don't play that game. If they're on medication to stop a nerve firing to another nerve, and then you go to adjust them, and that nerve can't fire to another nerve, you just wasted their time. Does that make sense? You got paid. If you want to play that game, I don't play that game. Yeah, that's somebody else you can be treating, right? So, great, you don't give them drugs, but the majority of patients that come into your office will be on them. So at least figure out, there's a really cool app, Hippocrates, it's free. And it's an app on your phone, you can just download it, and you could be against it, you could be for it, I don't care, but you should at least know what it is, right? So if a patient comes in, they're on like, you're in the clinic, and they're like, I'm on A, B, C, D. You're like, okay, so the next chance you get, you just look up and you see that they're on, a blank that could affect neuromuscular control. right? Like don't be ignorant about it. You know, go in and be like, okay, well, let's see what else we can do. Let's see how to work around this. Well, let's figure out how I can make your treatment the best I can. Cool? Cool. So we got ablative versus physiological. These are the two different kinds of lesions that you can have. Either a nerve can be cut, like think surgeons, like if a surgeon cut a nerve. That's an ablative nerve. Okay? Good luck firing through that. Right? Or you can have a physiological nerve, which we go back to the transneural degeneration or something like that, where the nerve's there, it's just not firing as well as it should. And as chiropractors, that's what we try to do, is we try to make those neurons fire better. Okay? So the physiological lesions, and actually there's like 90% of all lesions, physiological lesions are like 90%.
Really?
There's way more physiological lesions than there are ablative lesions. And ablative lesions are way harder to treat, but ablative lesions cause physiological lesions in other places due to that pooling, right? So a patient comes in with 8 different things wrong with them, right? They may have an ablative lesion somewhere, but it's caused other pools of neurons to decrease in their firing. So we can go back in as chiropractic neurologists and treat all those other pools that are physiological lesions due to this ablative lesion, where we can't do a whole lot about that ablative lesion, right?
Can peripheral nerves like regenerate to some extent?
Dude, I've heard so many people argue that. In terms of the axon, in terms of the neuron, in terms of... I heard it's super slow if it does, and you have a window of... It's like a year, and it grows like... This is what I've heard, and I'm not going to tell you guys like a fact if I don't know it for sure, but I've heard so many different arguments on it, so I'm not sure. But what I've heard is it grows really small, like between a millimeter and a centimeter for the axon. So like the end of the nerve that's trying to reach another nerve. Like a millimeter to a centimeter per month, and it happens for about a year, and if it doesn't hit anything for a year, it dies. And all the muscles, like let's say it goes to a muscle. If it doesn't reach that muscle, if it doesn't reach another neuron, everything else dies. So you see a lot of doctors, they'll come in, let's say, you know, a guy took shrapnel to a nerve, and he'll go down and he'll look at the muscles, because as soon as the muscles aren't there, and he sees that the muscles are completely like hollowed out and completely atrophied to where he's like, you know, there's not a nerve firing to that muscle's completely dead, there's not a whole lot we can do. Now, if they can't feel that part of their leg, and they can't control that part of the leg, but the muscle's still there, and the muscle's still full, they're like, game on, let's try it. You know, let's try to stimulate that. Let's try to adjust it. Let's try to do E-stim. Let's try to put a rebuilder on it. Let's try to do something to make that communicate with that muscle better. Let's try to save that muscle, right? So, from what I heard, it's if it does happen, the axon's super slow, and you do have a window that's very important for you to try to treat them before it just doesn't go to anything and then it dies. So, the other thing is blood flow. 50% of neurological disease is due to lack of blood flow, due to Blumenfeld's one of the books that we'll get later on. I think it's Nick, is it, or Tyler, is it the case studies, neuroanatomy through?
Yeah, I recommended 5, but I
Do what? Oh, okay, so you hear that? So try 3s, get it for try 4. It basically takes the nervous system and it breaks it down through case studies, because, I mean, it helps you learn. Okay, patient presents as this, and then it teaches you anatomy and stuff you need for class, but this is what it's actually going to look like. So blood flow is huge, which is why we emphasize rib adjustment.
I think they're going to change the textbooks.
Are they? Okay.
So if you're going to go buy one right now, get like neurology or
DeMeyer's is really good. Is DeMeyer's the not the differential diagnosis, it's the exam, right? Neurological exam. So if you get
John Patton's neurological.
Remind me at the end of club, we have a tab on our website that's recommended reading, and we have all those books on there. So if we're about to change it in class, we'll add that book too. So I'll show you guys some of the books that you guys can be getting to help you out with this stuff. So yeah, so if they don't have good blood flow, neurons aren't going to be doing that great, which is why we do a lot of pulse ox work in here too. So if you guys don't have a pulse ox in your doctor's bag, go ahead and grab one, because they're really important. Receptors from one side of the environment usually results in a greater activity in the ipsilateral cerebellum and contralateral brain. So this is what we did last time. This is why I was hammering this with you guys. If I adjust them on the left, what side of the brain does it go to?
Right.
If I adjust them on the right, what side of the brain does it go to?
Left.
Okay. Let's say, okay, from the receptor, it goes to the peripheral nerve. Where's the main point in the brain that's going to hit next? Huh? So let's say I adjust them. Give me the pathway of where this goes. Different parts that it'll bang around in the brain. Okay. So then it's got to go to the thalamus, and then, so that's what I was getting at. Is you've got to have a lot of input from that thalamus, and you've got to have that input from this cerebellum. This cerebellum is going to hit the same side pons medulla and the opposite side midbrain. The same side pons medulla is going to inhibit the IML on that same side. Okay, IML being your sympathetics, what revs up your sympathetics. And that cerebellar input from the adjustment is going to go to the opposite side midbrain, which is going to turn around and excite sympathetics from the same side. So when people say, oh, you adjust for sympathetics, or you adjust for parasympathetics, or you're going to have a sympathetic output or a sympathetic response no matter what you do. It may be more parasympathetic, you know, but you're gonna, I mean, you can't like go in and be like, boom, C3, I'm doing parasympathetic. Like, that makes you sound like you don't know what you're talking about. People won't trust you. Just so you know. So if you adjust them, you're going to have a little bit of a sympathetic output. Okay? Nervous system is multimodal, so you don't have to. So again, we're treating nobody else, a patient of chiropractic, nobody else is going to look at the whole patient like we do. So treat them like a whole patient. You don't have to only treat them with muscles and joints and moving a bone or whatever. We use a lot of light. We use sound. We use spinning. We do vestibular stuff. You know, we kind of go with the, you know, when Hippocrates came around like 500 years before Jesus, right? He was like from the least abrasive to the most abrasive. That was like one of his key points. We, as chiropractors, it's like we don't want to just give them a bunch of drugs, give them a bunch of surgery. We want to look at like, how can we stimulate this brain through chiropractic in better ways? When you guys study, you know, people hear like, okay, I actually chew the same gum when I study as I do, you know, when I take the test. Or I drink the same drink when I study as I do before I take the test. That's multimodal. You're trying to learn something with an added stimulus. So you'll see a lot of good chiropractic neurologists, they'll do different stuff. They'll combine an adjustment with light or sound, or whatever. Let's say it's an athlete. They combine an adjustment with that athlete's specific movement. If it's baseball, they'll look at a baseball throwing, right? And as soon as they see a breakdown in movement, that's when they'll pull out an activator and adjust them in that movement where the movement maybe broke, right? Which is pretty cool. So you can do light, sound, vibration. You can do anything, huh? Smell. Smell is super powerful. So you see a lot of PTSD patients where they get treated and they get treated with the smell. So if they're somewhere else and they can't be treated and they start to get revved up and anxious, they'll just pull out that essential oil, whatever, and smell it, and it's like they just got treated.
Guys, like, get some essential oils and use them to study. Smell your oregano oil when you're studying physio. Smell your lavender oil when you're studying, you know, whatever else you need to study. I don't know. Break that out before your test. Break that smell out. Smell it before your exam. I guarantee you it'll be better.
Mm-hmm.
Probably a letter grade better.
Hello, okay.
And you can get it from me.
Yeah.
There you go.
All right. I don't even know where I was. Did I already say the middle? Yeah, okay. All right, so brain output. So we know, and raise your hand if you have a manual already. Okay, let me see. I'm going to get you guys to turn to a page. For those of you who don't have a manual, crowd around somebody who does have a manual real quick. And I'm going to show you guys something. Show you guys something. As soon as I figure out what page it's on. Turn to page 23. It's going to look really, really intimidating for a second, and then we're going to break it down. So you guys are going to hear a lot of talk in this club when we talk about the mesencephalon, and people think like, oh, that's just a part of the brain that sounds really confusing. When I say mesencephalon, I just say midbrain, okay? So as soon as I say midbrain, you guys think mesencephalon. If I say mesencephalon, you guys say midbrain. I'll try to keep it simple and say midbrain as much as I can. Sometimes I have brain fart, and you guys just gotta stay with me. So the cortex, we're talking about brain output. So if I took 100% of brain output, close to 10% of that is volitional motor through corticospinal tracts. So that's your, when you move things, right, on purpose. The rest of that 90% is going to go down and kind of audit your autonomics. And it's going to kind of look at your parasympathetic and your sympathetic, and it's going to make sure you have good muscle tone. It's going to make sure you have good autonomic control. It's going to make sure your reflexes are good. A lot of your function, your day-to-day basic functioning is through that midbrain and through that, we're going to call that the PMRF, which is your pontomedullary reticular formation, also known as your pons, your medulla, or pontomedullary activating system, whatever. So we're going to take the cortex. There's a huge big black arrow that goes down from the cortex to the PMRF, because out of that 90%, so throw away the 10% that's volitional movement, we got that remaining 90%. The 90% of that remaining 90% is to stimulate the PMRF, and that PMRF's job is to dampen sympathetics. A reason why a dog has, like, what is it, 7 years to our 1 year? They did studies and they found that dogs have 7 times the amount of sympathetics at rest than humans do. We want to be in a parasympathetic state. Parasympathetics are good. It helps us digest food. It helps us stay normal. If you're at a more revved up sympathetic state, you see people like PTSD or in chronic pain syndromes or whatever, you see them sweating, you see their autonomics, you see their red skin, you know, you're just a different person when your sympathetics revved up. If I scared you right now, that's, you know, sympathetic. I don't know how many are try 1, but I feel like we all get that kind of stuff.
Jason, is that why people that are under constant stress tend to age quicker?
Yes, absolutely. And it also, so if you see chronic pain or chronic stress, it also shrinks your brain. So they'll do cross-sectional area studies of brain after people that have done, you know, gone through war, they've gone through really, really hard lives, and their brains are actually smaller cross-sectionally. Yeah. Which, hey, and that's a good point, is you're always killing off neurons that you don't use, right? But going back to plasticity, the neurons that you keep just work better, right? So our brain should be degenerating, but the neurons that we keep should be better. Guess the period of your life when you kill the most neurons? Undergrad. Yeah, people laugh, get it? Yeah, no, I mean, that's probably a big reason why. But I think it is because of that. I think it's because it's like little sleep, chronic stress, you do drink a lot, like a lot of those different things play into it. So it's just the neurons that you keep, you tend to use better because they just communicate better. Okay, so the PMRF, it's going to go down, it's going to inhibit that little thing called the IML. And the IML is what stimulates your sympathetics. So you think the sympathetic chain, it's going, so basically if I say inhibits the IML, you're going to be more parasympathetic. That's kind of confusing, but does that make sense so far? If I need to explain it without using the IML, I can. What's that?
What does IML stand for?
Intermediolateral cell column. So, in your the thoracic area of your, who's got a dry erase marker on? Or I think. Bye. You are awesome.
It's not like super thick.
So let's imagine, so everybody's seen a cross cut of the spinal cord, right? So it kind of looks like this. Right? So let's say this is the front, this is the back, anterior, posterior. In the thoracic area of your spinal cord, you see this part kind of branch out, and it looks like that. And these are the neurons that fire, and then so you've got your chain, the sympathetic ganglia out here, and out here. This part, so you think of, let me break down the word real quick. So intermedio, like intermediate, is in the middle of A to P. Right, in the middle. Intermediolateral is if I take it and cross-cut here, it's on the lateral side. Intermediolateral cell column. These are the nerves that fire to the chain ganglion that make you more sympathetic. Does that make sense? So we just use IML because I don't feel like saying intermediolateral cell column. Every time I talk about sympathetics, it gets old. Right? So, you guys have any questions so far? Alright, so the PMRF, that's about 90% of your brain output, dampens the IML for more parasympathetic daily living. The mesencephalon is about 10%. So what happens, you guys think, if the cortex fires down about 10% to the mesencephalon and 90% PMRF? if you've got a bad cortex? What do you see more come out? If you can't fire enough to the PMRF, what would you see in autonomics? You would see more parasympathetic or sympathetic? Sympathetic. What happens if the cortex doesn't get fired enough to by the opposite side cerebellum through movement? That's called cerebellar diastasis, by the way. That's a thing. So we have a bunch of fixations on the left. They don't move as much on the left. They have a stroke and they can't move. You see cerebellar diastasis to the opposite side cortex, and that cortex inability to control autonomics. So now we're changing autonomics. So that basically breaks down autonomics. We'll have a whole week talking about autonomic function and stuff like that. Okay. So going back to this, sensory input goes to central processing. Central processing is like the mom that walks into the room and the lamp is broken. You've got 4 kids and they're all like, he did it, she did it, they did it, it wasn't me. It's the mom's job to figure out, okay, what's actually going on. If you've got a bunch of fixated joints, they're all to the right, it feels, your brain thinks you're going to move left, right? If your eyes are off to the right, or your vestibular system is saying we're going right, and your joints say you're going left, your brain's like, hang on. Doesn't make sense. Right? And your brain uses up a ton of energy to figure out the right story, to figure out who's lying. And when your brain uses up that much energy to figure out who's lying, it can't do stuff like heal you, or executive function, or daily living, or all that kind of stuff. So we want, between proprioception, between vision, between the vestibular system, we want all those things to be telling the same story all the time. Then your brain can focus on other stuff. Right? Okay. How do we normally, what's the best window, do you guys think, between, if I were to use only sensory test or only motor test, what do you guys think I would want to use if a patient came in, I had 30 seconds? Would I test? Who thinks sensory? Okay, cool. How many think motor? Okay, cool. Why motor?
I think walking gait.
As they incorporate sensory.
Bingo. So if you test motor, if you test like, a Babinski, if you test something like that, you're not going to have a motor output if you don't feel it, right? So it's a really quick test to say, okay, do you have sensory? Yes. Do you have motor? Yes. Okay. In order for you to have motor, your sensory's got to be somewhere. Rule of thumb. Okay. Going back to the same thing, why chiropractors are so important. We deal with the mechanoreception. That's the sensory constant. The sensory constant that we have is gravity. We talked about the neurons, if they don't receive activation, they die. So we use gravity and how we perceive gravity to keep all the neurons alive, right? So mechanoreception is the only constant source of sensory input, and that's gravity. So how our joints are responding to gravity, how our muscles are responding to gravity, all that kind of stuff. The nervous system is also continuous. So we know that the central nervous system affects peripheral, the peripheral affects the sensory, or the central nervous system. So if we adjust peripheral, it's going to have a change in the central nervous system. If we do something to the central nervous system, it may affect that joint, which brings us to the next point, is not all subluxations. So how do I want to explain this? I'll explain it, and I think I used a stroke example later on in this PowerPoint. So patient Tim gets a stroke. Did his stroke affect his joints moving and being fixated? Or did his moving and being fixated cause a stroke? I don't remember which one I told you first. So the stroke caused this, right? Does anybody want to argue that point with me? Right? So we know that if we change the central nervous system, it could change the peripheral nervous system. It could change joint juxtaposition in a peripheral joint, or in muscles, or in something else. So does that kind of give you guys an idea on why we kind of care about both? We don't want to adjust their neck and be like, yeah, it fixes your body. It's like a safety pin. Right? You have to do both. You have to know about both. You want to know about the longitudinal levels of a lesion. You want to know about, hey, maybe they've got what we consider a subluxation in the brainstem. There's not a joint up there, but I think the brainstem's not firing. The brain doesn't have a good communication with the rest of the body in this area, or right here, or right here. And there's different diseases in each one of these that you want to rule out. Right? Because you don't want to be treating something, let's say they're sick here, you don't want to be treating something over here, and then they come back 8 weeks later and they're like, yeah, I still don't feel very good. You know what I mean? You want to treat your patient right. You want to know where it is. So you want to be able to identify, like, okay, I know to test their cortex. Their cortex looks good, right? Okay, now I want to look down to their brainstem. Their brainstem, And then if their brainstem's, maybe I might see some findings in other areas. So that goes to differential diagnosis, which we'll get in neurology later on. So for right now, just know that there's different places where we want to kind of look. It's not all about one joint being out of place in your lumbar spine and your cervicals or something like that, or an elbow or whatever. Okay? Okay, so what is a subluxation? This is the best definition that I found, and this is the one that's actually in the manual, so I just used it, and a lot of that stuff is just coming straight from the manual. So it's a reflexive myospasm of intrinsic spinal muscles creating a joint misalignment or subluxation, which produces decreased motion and decreased, or apparently it's just like wrong or different feedback to the brain. So we already addressed that it's reflexive. It's not, you didn't put it there on purpose, right? And then for a lot of people who think, well, it's only a subluxation if it's an intrinsic spinal muscle, that's kind of what that whole talk was about. I think it could be in different places in the nervous system. It just doesn't have to present as a bone out of place. The bone out of place is a passive tissue, right? So like passive tissue meaning like a muscle has nervous system recruitment in it. The bone kind of doesn't. I don't care if the bone's out of place. That's why I said if the bone's out of place, as long as you have good movement and good input to the brain, we're good. Right? Roger Sperry, a Nobel laureate, demonstrated that 90% of the energy entering the brain is from the spine. The more mechanically distorted a person is, the less energy available for thinking, metabolism, and healing. So just kind of reiterate like what we were already talking about. The more people are actually moving when they should be moving, the healthier they should be, because they have better central integration, better motor output. Okay. And then there's the stroke guy we were talking about. So now let's do some stuff. We've been sitting for too long. So we're going to do, who was here when we showed that video when the guy was testing that girl for all the primitive reflexes? Most people here. We're going to do that. We're going to check everybody for primitive reflexes. I have somewhere, does anybody have those cotton things? We got a couple people do? Okay. So, I can copy it up here.
Tell us what we need to bring back.
Okay, and yeah, so now on if anybody's not on Facebook, y'all get on the Facebook page because I can do it like, whoa, what's weird. I'll start posting stuff like a day or two in advance for you guys to go get either reflex or whatever. I had a backpack at some point. You guys do a backpack. Yeah, we can do everything.
Jason, can we choose a pen?
Yeah, we can. I brought like a ton of them. Yeah, and that's if you guys have. That's what I was saying. If you guys have a bag for reflex camera, that'll work. All right, can I just borrow somebody's right now just to get the show on the road, and then we'll come back and. Okay. Yeah. So I need a person, a volunteer. All right, Bryce. We're gonna get you to stand first. So let's go ahead and run through all these, and then we'll get you guys to do them. Would you guys rather do it one at a time, or would you rather do like 6 of them, and then you guys just come grab us if you need us? One at a time. Okay. So everybody. Oh no. Raise your hand. One at a time. Raise your hand for all the above, and then go do them. Okay. When? Okay, so the moral reflex, I think from what I understand, this is more basal ganglionic, okay? If I clap my hands and Bryce falls and does a trust fall and I catch him, he should be able to do that to a point without stepping back, okay? He should be able to gate that response. So it's cortical inhibition of that urge, yeah, I'll do it right now, of that urge to, okay? He should be able to inhibit. So I'm going to clap, you're going to fall straight back, and I'm going to catch you, okay? Okay. Common sense move, if you don't think you can catch a patient, don't try this move. Don't play a guessing game, because you're like, wow, hey, how much do you weigh? I didn't know I could do that. Okay. So positive is what? Positive finding is if you... Right. So they should be able to do that, okay? That's a moral reflex. Rooting reflex. Coming around and just look straight ahead. I'm doing this right in the light. So you guys just don't do this right in the light, okay? You should be able to come up and stroke his cheek from the mouth up. Think of like the Joker scars in Batman, right? Start from his lip to go up. So we're going to go like that and like that. And why do you have a primitive reflex? Babies can't volitionally move, right? So if a baby feels something on their cheek, it teaches them to look left. If they feel something on the right cheek, it teaches them to move right. Rolling, whatever. And then eventually, once you learn those moves, you inhibit that because you don't need to do it. It's what helps babies learn how to move. So, positive finding is a twitch, right? So it should be, and you'll be, I'm actually, I bet.
You go away from it?
Yeah.
Huh?
So you go away from it?
You'll just see a twitch. I've actually seen both.
Really?
So any twitch, we gotta kind of investigate a little bit. So positive finding is a twitch. Normally it would be to it, because think of like a mom's food. Whatever. I don't know who's listening to me right now, so we won't play that game. So normally it'll be, you see a twitch, it'll be to that side. You'll see either head rotation or a mouth to that side. They're hungry. You know? Yeah, they gotta eat or something. Let's actually, I actually need you to lay down really quick, so let's do this. Can I get you to take your shoes off real quick? Yep. You guys have a problem with feet, you're about to have a bad time.
Jason, on the reading reflex, do the eyes need to close more?
Shh, I don't know. That's a good question. I'd say yes, but I've seen it both. Is that how they teach it? Okay, so hey, let's just do it with eyes closed. Does anybody have any input on that? I'm not the be-all, know-all. This is why this is a community thing, right? So if you guys want to try it, eyes closed, let's do it with eyes closed. Okay? All right, so for this one, there's a plantar reflex. This is also called a Babinski, and it's also an upper motor neuron lesion thing. So you can either poke, you can actually come up and, by the way, like you don't like have to stab them, but if you just tickle them, it doesn't work. You actually have to make it somewhat abrasive for them to actually register, right? So I just take the tip of a reflex hammer, and I come up the lateral aspect, and then cut across. A positive would see his big toe up and his toes flare out. What he should do is go toes down. If it goes down then up, doesn't count. It's an initial up and then a spreading or a fanning of his toes. So going up, they went down. They went down. Cool? Positive is a Babinski sign, and that's when the big toe goes up and you see toes planting, okay? Alright, so we're going to call that one plantar. The grasp does the same thing as if we take this, and you can sit up, you face up. Over your hand. You can just come out, come out, come out. So this is the same thing. When a baby feels something like, sorry, like this is going to like crush your hope and drink. Like when you like grab a baby's hand, you think they're holding your hand. It's a reflex, they're not trying to do it. So they don't really like to do that. But for our sake, we're going to do it because Bryce should be able to inhibit closing his hand, right? He doesn't have a twitch to try to go on and grasp whatever I'm trying to do, right? So, out, 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 nothing. So Bryce is pretty good. He's a smart dude. Most of us should be okay, right? We might find a couple abnormalities, but for the most part, we should be okay. Okay, so for this one, it's a spinal gallant. So for this one, I'm going to move this really quick. You actually have to get on your hands and knees. Yep. And then I'm going to have to, yeah. Are you cool with that?
Yeah.
Cool. Okay. So this is the one I was talking about before, if you guys weren't here, that the doctor actually did to a baby in the mom's stomach. When the baby wouldn't roll in, she was having a hard time with labor, the baby wouldn't drop in. So, and I'll do it and then I'll explain what I was talking about. So, you should go right on either side of the paraspinals and you should just stroke up. And if it was a positive, he would, yeah. So, and then there's also on the other side. And then he would turn. So that's a sideways. If you do them at both, you would see his stomach drop like that. Okay? So you would see 1, 2, and then 3. And then that one's, what is that called? I forgot what that's called. That's the Perez. So a spinal Perez is when you do both. A gallant is when you do one at a time. And then I was telling them last week a story about the mom came in, she was trying to have a natural birth, the baby wouldn't drop in. So the doctor went up and did a spinal collant on the baby's spine, but through the mom's stomach. And the baby turned and dropped in, and she had the baby like right after that. So it's pretty cool. So that's what you're trying to do in a baby. And here's the thing too, and it's in those manuals. It basically breaks down when there's a time frame when those babies should lose those reflexes. So if you see people that have brain damage, they have bad cortex, you see them with upper motor neuron lesions. Now I feel like a Gary or somebody.
And remember, there's that study that's posted on the website that talks about, I think it's actually Milo, talking about how with people with autism, there's a link between not losing those primitive reflexes and developing things like autism, different brain dysfunctions.
Instead of losing, what'd you say?
So because a lot of people who have autism, they'll still show these primitive reflexes. So now they're linking how it's a loss. If you don't lose those primitive reflexes as you develop, it can help you, or it can lead to those imbalances in different hemispheres.
Wow. So I'll leave that open. You guys have about 10 minutes. So see if you can grab a